Hello and welcome to the topic Pulmonary Embolism in the Respiratory Medicine module. By the end of this topic, you should be able to define pulmonary embolism, explain the causes and pathophysiology of pulmonary embolism, describe the clinical features of pulmonary embolism, outline the investigations to diagnose, and to discuss the principles of management of pulmonary embolism. Let's get started. Pulmonary embolism is a blockage of an artery in the lungs by a substance that has moved from elsewhere in the body through the bloodstream. It is when a blood clot or a thrombus becomes lodged in an artery in the lungs and it blocks the blood flow to the lungs. Under normal conditions, microthrombi, which are tiny aggregates of red cells, platelets, and fibrin, are formed and lies continually within the venous circulatory system. Although pulmonary embolism can arise from anywhere in the body, most commonly it arises from the calf veins. The venous thrombi predominantly originate in the venous valve pockets and at other sites of presumed venous stasis. To reach the lungs, thromboemboli travel through the right side of the heart. Pulmonary thromboembolism is not a disease in and of itself, rather, it is a complication of underlying venous thrombosis. Pulmonary vascular occlusion occurs and impairs gas exchange and circulation. In the lungs, the lower lobes are more frequently affected than the upper lobes, with bilateral lung involvement being common. A study in 2007 looked at the frequency of different symptoms and signs in patients who were diagnosed with pulmonary embolism. The relative frequency of common clinical signs include tachypnea, with respiratory rate more than 20 breaths per minute, seen in 96% of patients, crackles, where there's 58% of patients, tachycardia, with a heart rate of more than 100 beats per minute, and fever with a temperature more than 37.8 degrees Celsius. It is interesting to note that the Wells criteria for diagnosing a pulmonary embolism used tachycardia rather than tachypnea. All patients with symptoms or signs suggestive of a pulmonary embolism should have a history taken, examination performed, and a chest X-ray to exclude other pathology. Physical exam findings are quite variable in pulmonary embolism and for convenience may be grouped into 4 categories as follows: massive pulmonary embolism, acute pulmonary infarction, acute embolism without infarction, and multiple pulmonary emboli or thrombi. The presentation of pulmonary embolism may vary from sudden catastrophic hemodynamic collapse to gradually progressive dyspnea. Most patients with pulmonary embolism have no obvious symptoms at presentation. In contrast, patients with symptomatic DVT commonly have pulmonary embolism confirmed on diagnostic studies in the absence of pulmonary symptoms. NICE updated their guidelines on the investigation and management of venous thromboembolism or VTE in 2020, and one of the key changes was the use of pulmonary embolism rule-out criteria, which is the PERC rule. All the criteria must be absent to have negative PERC result. This should be done when you think there is a low pre-test probability of PE, but want more reassurance that it isn't the diagnosis. This low probability is defined as less than 15%, although it is clearly difficult to quantify such judgments. A negative PERC reduces the probability of PE to less than 2%. If your suspicion of PE is greater than this, then you should move straight to 2-level PE well score without doing a PERC. If a PE is suspected, a 2-level PE well score should be performed. Clinical probability simplified scores include PE being likely, which carries more than 4 points, and PE being unlikely, where you have 4 points or less. If a PE is likely, which is more than 4 points, arrange an immediate computed tomography pulmonary angiogram or CTPA. If there is a delay in getting the CTPA, then interim therapeutic anticoagulation should be given until the scan is performed. Interim therapeutic anticoagulation used to mean giving low molecular weight heparin. NICE updated their guidance in 2020. They now recommend using an anticoagulant that can be continued if the result is positive. This means normally a direct oral anticoagulant such as apixaban or rivaroxaban. If the CTPA is positive, then a PE is diagnosed. If the CTPA is negative, then consider a proximal leg vein ultrasound scan if DVT is suspected. If a PE is unlikely, which means 4 points or less, arrange a D-dimer test. If positive, arrange an immediate computed tomography pulmonary angiogram. If there is a delay in getting the CTPA, then give interim therapeutic anticoagulation until the scan is performed. If negative, then PE is unlikely. Stop anticoagulation and consider an alternative diagnosis. The consensus view from the British Thoracic Society and NICE guidelines is as follows, where CTPA is now the recommended initial lung imaging modality for non-massive PE. Advantages compared to VQ scans include speed, easier to perform out of hours, a reduced need for further imaging, and the possibility of providing an alternative diagnosis if PE is excluded. If the CTPA is negative, then patients do not need further investigations or treatment for PE. VQ scanning may be used initially if appropriate facilities exist, the chest X-ray is normal, and there is no significant symptomatic concurrent cardiopulmonary disease. VQ scanning is also the investigation of choice if there is renal impairment. However, this doesn't require the use of contrast unlike CTPA. D-dimers are sensitive up to 95 to 98% but has poor specificity. Age-adjusted D-dimer levels should be considered for patients more than 50 years. For ECG, the classic ECG changes seen in PE are a large S wave in lead 1, a large Q wave in lead 3, and an inverted T wave in lead 3, where you have your S1, Q3, and T3. However, this change is seen in no more than 20% of patients. Right bundle branch block and right axis deviation are also associated with PE. Sinus tachycardia may also be seen. Next would be a chest X-ray. A chest X-ray is recommended for all patients to exclude other pathologies. However, it is typically normal in PE. Possible findings include a wedge-shaped opacification in the case of infarction. VQ scan is sensitive of around 75% with a specificity of 97%. Other causes of mismatch in VQ include old pulmonary embolisms, AV malformations, vasculitis, and previous radiotherapy. COPD gives matched defects. CTPA is one of the best investigations for diagnosing a pulmonary embolism. However, peripheral emboli affecting the subsegmental arteries sometimes can be missed. NICE updated their guidelines on the management of VTE. Some of the changes include the use of direct oral anticoagulants as first-line treatment for most people with VTE, the use of DOACs in patients with active cancer as opposed to low molecular weight heparin, as was the previous recommendation, outpatient treatment in low-risk pulmonary embolism patients, and routine cancer screening is no longer recommended following a VTE diagnosis. As for outpatient treatment in low-risk PE patients, deep vein thrombosis has for a long time been treated on an outpatient basis. In contrast, patients with any form of PE were typically admitted. However, in recent years, patients with a new diagnosis of PE who are deemed low risk are now increasingly managed as outpatients. NICE formally supported this approach in their latest guidance. NICE recommends using a validated risk stratification tool to determine the suitability of outpatient treatment. There's no guidance given as to what tool should be used. The 2018 British Society guidelines support the use of Pulmonary Embolism Severity Index score. Key requirements would clearly be hemodynamic stability, lack of comorbidities, and support at home. The cornerstone of VTE management is anticoagulant therapy. This was historically done with warfarin, often preceded by heparin until the INR was stable. However, the development of DOACs and an evidence base supporting their efficacy has changed modern management. The big change happened in 2020 guidelines on the choice of anticoagulants, where we saw an increased use of DOACs. Apixaban or rivaroxaban, both DOACs should be offered first line following the diagnosis of a PE. Until the diagnosis is confirmed, NICE now advocate using a DOAC once a diagnosis is suspected, with this continued if the diagnosis is confirmed. If neither apixaban or rivaroxaban are suitable, then either low molecular weight heparin followed by dabigatran or edoxaban, or low molecular weight heparin followed by a vitamin K antagonist, which is warfarin. If the patient has active cancer, then previously low molecular weight heparin was recommended. However, the new guidelines now recommend using a DOAC unless this is contraindicated. If renal impairment is severe, which means eGFR of less than 15, then low molecular weight heparin, unfractionated heparin, or low molecular weight heparin followed by warfarin can be used. If the patient has antiphospholipid syndrome, specifically triple positive in the guidance, then low molecular weight heparin followed by warfarin should be used. As for length of anticoagulation, all patients should have anticoagulation for at least 3 months. Continuing anticoagulation after this period is partly determined by whether the VTE was provoked or unprovoked. A provoked VTE is due to an obvious precipitating event, such as immobilization following major surgery. The implication is that this event was transient and the patient is no longer at increased risk. An unprovoked VTE occurs in the absence of an obvious precipitating event, such as there is a possibility that there are unknown factors, for example mild thrombophilia, making the patient more at risk from further clots. If the VTE was provoked, the treatment is typically stopped after the initial 3 months, 3 to 6 months for people with active cancer. If the VTE was unprovoked, then the treatment is typically continued for up to 3 further months, sometimes 6 months in total. NICE recommend that whether a patient has a total 3 to 6 months anticoagulant is based upon balancing a person's risk of VTE recurrence and their risk of bleeding. The Hasbled score can be used to help assess the risk of bleeding. NICE states that we should explain to people with unprovoked DVT or PE and a low bleeding risk that the benefits of continuing anticoagulation treatment are likely to outweigh the risks. The implication of this is that in the absence of a bleeding risk factor, patients are generally better off continuing anticoagulation for a total of 6 months. Now, how about thrombolysis? Thrombolysis is now recommended as the first-line treatment for massive PE where there is circulatory failure in the case of hypotension. Other invasive approaches should be considered where appropriate facilities exist. Patients who have repeat pulmonary embolisms, despite adequate anticoagulation, may be considered for inferior vena cava or IVC filters. These work by stopping clots formed in the deep veins of the leg from moving to the pulmonary arteries. IVC filter use is currently supported by NICE, but other studies suggest a weak evidence base. Complications of pulmonary embolism include sudden cardiac death, obstructive shock, pulseless electrical activity, atrial or ventricular arrhythmias, secondary pulmonary arterial hypertension, cor pulmonale, severe hypoxemia, right to left intracardiac shunt, lung infarction, pleural effusion, paradoxical embolism, heparin-induced thrombocytopenia, and also thrombophlebitis. Now, to summarize, pulmonary embolism is an event of a blockage of an artery in the lungs due to a clot. DVT and hemodynamic compromise of the underlying venous thrombosis are among the risk factors and causes for pulmonary embolism. Common signs and symptoms to expect could include tachycardia, cyanosis, shortness of breath, and hypoxia. As for investigations, do not forget to do a lab coag profile and arterial blood gas to look at the severity of hypoxemia or respiratory failure. Imaging studies such as CTPA and other functional studies such as a VQ scan may be helpful in the diagnosis of pulmonary embolism. Pulmonary embolism can be treated medically and surgically depending on the severity of the condition. Thrombolysis is indicated in patients with massive PE. Otherwise, generally, patients are treated medically using anticoagulation therapy. We have come to the end of this topic. Thank you.